Everything rises and falls on leadership. The ability to lead well is fueled by living your cause and purpose. This podcast will equip you with the tools to do just that. Live and lead with cause and purpose. And now, author of the book, The Anatomy of Leadership, and our host, Chris Como.
Hello and welcome. I'm so excited today. We have two special guests with us today. We have Andrea Hale, who's the CEO of Valley Hospice, and Raianne Melton, who's the Director of Clinical Services for Professional Services for Axxess. Welcome, ladies. It's so good to have you both.
Thank you. Happy to be here.
All right. Well, let me introduce you just a little bit further, and then we're going to jump in because we're going to be talking about hope today. This is actually a podcast I've been wanting to do for quite a while, and we actually had scheduled it in this time of the year, knowing that the preliminary wage index for 2027 would be out. So let me introduce Raianne first. So Raianne is the Director of Clinical Services for Professional Services for Axxess. In this role, she serves as a subject matter expert in hospice and palliative care, assisting in the creation of training and certification courses for these specialties. Raianne also supports patient engagement as a consultant for Axxess's CAP solution, and she is an ANCC lead nurse planner and is a member of the Alliance for Education Work Group, the Emerging Models and Innovative Care Work Group, and is an Alliance Grassroots Ambassador. She is the recipient for McKnight's 2026 Pinnacle Marketplace Influencer Award. That's pretty awesome, Raianne. And she has 20 years of experience in hospice care with various companies. And one of her most recent roles, she served as the Director of Clinical Strategy for Banner Health, where she was responsible for developing strategic education to support current and future business opportunities and redefining the delivery model for palliative care programming to improve patient outcomes. And so, Raianne, again, it's so great to have you. I tell you what, I'm going to ask you this now. What's your superpower?
Well, this was a kind of a tough one for me because I don't always think of myself as having a superpower. But after a lot of consultation with my family and colleagues, I think that my superpower is that I just care. I care about patient outcomes. I care about the services that people deliver. I care so much, it moves me to action. So I guess caring is my superpower.
I love that, Raianne. And I'm so glad I just keep asking this question because, I'm not a very bright guy. I just get to interview amazing people like both you ladies. And then I asked that question and I could see it in action. In fact, let me introduce Andrea, and then I'm going to tie together why I just reacted in that way. Because the first time I got you two together, it was like kind of combustible passion and caring all over the place, actually. So Andrea Hale, she's an RN, MBA. She's the Chief Executive Officer of Valley Hospice, a mission-driven nonprofit serving the Ohio Valley for more than 40 years. She has over 2 decades of experience from bedside nursing to executive leadership. She brings a grounded clinical perspective to the future of both palliative care and hospice. Andrea is passionate, and I'll put passionate capital exclamation point, about defining what is truly exceptional 5-star care. What does that look like across the continuum, with a focus on the holistic expertise and competencies required to care for the seriously ill and dying. She's a strong advocate for advancing palliative care while protecting hospice as the holistic clinical specialty for the final stages of life, ensuring each remains distinct, purposeful, and rooted in clinical excellence. As healthcare shifts towards value-based care, she believes innovation and payment must never disrupt the core fundamentals that created the expertise of caring for the dying, which is also going to be a great segue to what we're going to be talking about. So, Andrea, what is your superpower?
Well, we've done these exercises a couple of times, and it keeps coming forward that storytelling. So I love to tell stories in a way when things are complex or there's a lot of data and I see like question marks in people's eyes. Then I take that data and I can tell a story that kind of helps them understand it. And from a patient care perspective, if we've had a situation where maybe we should have done it a little differently, or being able to look at it through the eyes of the patients and the families, then I can tell a story from that perspective. But I do, underneath all of that, my mother taught me to come from a place of love. So as passionate as I am, and, I do share that passion, and I like to have conversations around different topics, I try to ground that always in love.
That's well said. And again, to mirror that back to you, I could so see that. And there were some cool little breadcrumbs in your bio, just being very passionate. Hospice is a brilliant model of care, the competencies by the bedside. And so the first time you two got together, I can't remember exactly what the catalyst was, other than I think it was me being kind of a little bit of a pest as I normally am, was people like, hey, I'd like to get you on a call. And Andrea, you were certainly very influential over me about, hey, do you really understand hope and where it's going? And I'm like, honestly, I don't. Certainly not to the extent that you do. And you're like, you should go find an expert for hope. And then lo and behold, the Axxess team connected me with Raianne, set up a call with both of you. I think it was early this year or right before Christmas. And it was like just explosive energy, caring and love, but passionate around what hope is and where hope is going, which is really like, probably starting last year, I just felt like we needed to do a show around hope. We talked with Judy Lund-Person and Annette Kaiser last year just about the mechanics of it. But both of you had been kind of planting some seeds with me since I've gotten to know you about, do you understand the chassis that this is? And so finally got you two together, and here we are. So are we ready to jump in?
Absolutely.
Yes.
So last year's home health wage index, there were some changes in there that caught a lot of providers, I'll say, off guard. When you look at hospice today, what signals in that home health wage index that maybe you believe a similar recalibration is coming for hospice? And maybe where do you think leaders are underestimating the impact of that?
Well, I can go ahead and speak to that. One thing that I think that we need to be very cautious about is thinking that the headline of the wage index is really what we need to be focused on as leaders. That is not the case. And when you really dive into the 2027 hospice proposed rule, what we're seeing is that the 2.4 applies to national payment. Where they really are going to get us is in the CBSAs, those at the county level. And it's really amazing how many counties are targeted for the full 5% decrease. So, I live in Arizona. My county, the state of Rhode Island would fit into my county. So most hospices serve one county. When I worked in Springfield, Illinois, we serviced like 15 counties. And if you're an organization that is servicing a multi-county radius, you may be getting several levels of reimbursement based on the county. So as a leader, you're really going to need to focus on what model your care over what the actual reimbursement is going to be based on the CBSA.
Andrea, would you like to respond as well?
Oh, I agree with everything that Raianne said. And I think it wasn't one change, it was a stacking effect that people underestimated. They updated a wage index. They recalibrated the case mix. There were several things stacked in there. Like you said, if you just looked at the headline, then you put all those things together, and in your net and in your margin, you were shocked. And I'll take it back. When I look at this year's change with home health, I take it all the way back to 99 in the Oasis when I was in home care, and we were part of the beta for Oasis in our home care. And so when you look back there, and as soon as they said hope, I'm like, this looks like, smells like Oasis. I mean, it just does. And so that was on paper, and that's the difference. That assessment was on paper, so it was easier for us to implement. It still wasn't easy as far as the changes that we're looking at outcomes, but you saw that came, and then you looked at the case mix, and reimbursement followed with the outcomes. And so as soon as hope hit center stage, and we were a pre-alpha and alpha, it was just very clear that we were the last one standing, and we were going to evolve the way that the Oasis did. And now you see this last update, and that's just going to be the progression, our future moving forward. Mm-hmm.
So Andrea, I didn't mention that in your bio, but you were in home health when Oasis came about. And then didn't your hospice, weren't you guys part of the demo of hope? Did I misremember that?
Yeah, we were the pre-alpha and alpha for hope in our hospice. And then it was during COVID, so we were almost going to, it's unusual to do the beta, but we just couldn't because of staffing. And we just, they listened. We provided a lot of input. Our staff leaned into it. And, I'm really impressed with what CMS produced through that, the thoughtfulness that they put into it and how to move us into this space. And that was our experience with doing the pre-alpha and alpha with the Hope tool.
Well, let's jump into it. So maybe some of our listeners, for someone who hasn't maybe been living and breathing this, how would you explain the Hope tool? What is it? What is it designed to do? And why does it matter for the future of hospice?
Well, yes, it basically is an assessment tool, right? It's an assessment tool that's replacing the HIS for the HQRP data, quality data. And it's going to, in real time, look at symptom management, responsiveness, and the outcomes, ultimately, of our patient's experience. Right now, we have the CAP score, which, if you ask my brothers and I, where our parents both had Valley Hospice, what our perception of their care was, that's through our eyes. But what the Hope's going to do for the first time is going to give real-time data and assessment of the patient's perception of their symptoms being managed, the responsiveness, when they're able. Those answers will become from the patient. So, it's that's what it's going to bring to the hospice is finally, what are our outcomes? What do our patients experience? And I think that's a good thing. I think that is the next step. And right now, it's just a process. They're really tiptoeing into this, and that's different from Oasis, where we're just like, all of the things we had to do at once. Like right now, it's just a process. Did you show up? Did you identify that they have symptom impact? And did you show up? That's all we're monitoring. And then the next phase is, then we're going to look at the outcomes. So that's
You think that's why some people maybe think about it? Like, it surprises me. You and I are at some conferences sometimes, and we're surprised by, other than the initial kickoff last year, certainly got some airtime, but it doesn't seem like it's getting the airtime as much as you would expect because of where you and others believe it's going. Do you think that's kind of because it's just focused on process right now, that why people might be miscalculating its future impact?
I wonder that. And because of our, being pre-alpha and alpha, and I have my Hope manual that's 1.00, but they already have 1.02. And I watch the outcomes, the objectives very, very closely. And it talks about the standardized data. That's number one. Number two, to inform future payment and quality improvement. So they're saying it in their objectives, in their Hope manual. They've given us this information, but there's so much out there that's changing in our world that maybe that's just not. And if you haven't been through Oasis, and maybe you're just not looking at this is the way to position us as value-based care. It really is. Raianne, I don't know if you'd agree.
Yeah, Raianne, what would you like to add to all this about how would you explain it, what it's designed to do, and maybe where it's going?
Right. Well, I think you're going to hear Andrea and I say over and over, you're going to hear the term value-based care. Mm-hmm. And I think that you, as a hospice leader, if you care about what your future is going to look like, you need to be really looking into this and embracing it. So this is not CMS's first rodeo. And, we know, as my good friend Jennifer Kennedy from CHAP says, hospice is always at the caboose of the home health train. And so, it took 20 years for value-based purchasing in home health from when they initiated the Oasis assessment to when they implemented value-based purchasing. You know what? They're not going to take that time with hospice, guys. You need to be prepared that it's going to happen very, very quickly. And yes, we are just in the process stage of Hope, which I think will only benefit all hospices because we're finally documenting in a systematic and regulated way about what the symptoms are, what the impact is to the patient, and what we're going to do. So that's only going to help us. But I think that, we need to be prepared that this is all about that future payment changes. And as hospices, we're going to need to be more aware of data. We're the kind of the feeling business, right? We do a lot of things based on gut reaction. We're going to have to be a little bit more analytical and data forward as we proceed forward with hope.
This is so good. I think I'd shared this with Andrea before, but I read a book about Socrates. It was kind of fascinating. And so Socrates coined a term. I'm going to butcher it. It's a Latin word, but it's about is EUIDEMA, Eudema? I don't know if this is the right way to say it. But basically, Socrates was talking about, and this is like 500 years before Christ, about what is the measure of a good life. I think this is part of our problem, right, in hospice, is that, there's some people say, well, you guys have been talking about quality forever and you still don't have a good measure. Well, the CAPS, to your point, is like post-experience of the patient and family or the most involved caregiver. But how do you measure for the one who's experiencing the care? And when we tell these beautiful mission moment stories about beautiful closure, maybe even beautiful family reconciliation before someone passed away. Yes, good pain symptom management. Like, how do you put that in a measure? And I think that's where we've wrestled. Like, how do you measure the end of a good life that we help facilitate that? But yet we're at a time, right, where we just can't throw our hands up to that anymore. And the other thing that strikes me, Raianne, just listening to you is that it took quite a while for home health to get there in value-based payment. We're not going to have that luxury of that much of a runway. Okay, I thought that's what you're alluding to.
We are not going to have that runway. I will be surprised. I don't have a crystal ball, but I will be surprised if we don't have some kind of value-based care by 2030, definitely by 2035, but I will be shocked because they're clearly not only on the road to, having more data around outcomes, they're also on a mission to reducing out of the hospice benefit Medicare spending, which is just astronomical. $1.9 billion was spent last year in out of the hospice Medicare for hospice beneficiaries that was spent outside of that benefit.
Gotcha. Yeah. The what we call the non-hospice spending.
Exactly.
Yeah. Well, here's a good segue question then. So if hospice is going to experience this similar shift that home health has seen, what are the first order financial consequences, or maybe said a better way, what should the CEOs and leaders be doing right now to prepare and mitigate the risk? Because we know, right, when you look back every time Medicare does something like this, the per unit revenue goes down. Like, right, the outcome of Oasis was not that they got more money necessarily, although you can make the argument, well, the ones who are doing the best of the best, maybe they did, but overall, maybe the portion of the pie maybe shrunk via the Oasis. So that may be what they're trying to do is create more quality, but also maybe shrink how much expenditures, and hopefully maybe that'll be for the ones that are not doing such a good job. But what do you guys think?
I think we just need to double down on quality, Chris. And this is what we do. For the hospices that are focused on aggressive symptom management, and their RN case managers are trained that way, we don't let people sit in pain, severe, moderate pain. We make changes, then we call that night. And if it's not better, then we go the next day. That's what we do. So to double down on your quality and just look at this and this is what we talked about here, we just need to right now practice the expectation, and it's already our expectation, is severe to moderate symptoms should be managed in 48 hours. Who would want to not have their severe to moderate symptoms? That's the cornerstone of who we are. Then you can move to the mind, body, spirit, right? If your physical symptoms aren't managed aggressively and you don't have, median length of stay, ours is around 11 days, you're not able to face those psychosocial, emotional, and spiritual issues if you're breathing in pain. So I just would say, look at that as this is doubling down on that quality and showing the industry that yes, we've been doing it. Now we're just getting measured on it. And we welcome that opportunity to show the those that are going to influence our payment, that there are great providers out there. And I also believe that our system, as we know, per diem is set up that people can game that system, and there isn't the accountability on outcomes. There isn't accountability on you get paid whether you go or not. And the whole per diem system has set up some profiteering that has just been proliferative over our industry. And now we've seen the shift of the market. And so this is another opportunity that now, you have to be there. You have to show up. You have to show that you've managed symptoms, and there's accountability around being a hospice provider that is needed.
Well, I love Andrea's response. I think that we can't think of hope as a form to be completed. It needs to be thought of as a care management tool, and that we really need as leaders to operationalize documentation into care management. And, really look at how we're providing care, how quickly we're providing care, and where is that spot where we're missing the mark. Like, one of the things as a hospice administrator or clinical director that would make me crazy is a call for supplies from a family on the weekend, or a visit for a symptom that should have been handled during a regular visit. So how do we identify those misses and make sure that we're really tightening up how we do the work, how we focus on that, and how we really think of that care in a manner of we're the managers. And I know we have case managers, but how many case managers get real training in how to be a case manager? Not all hospices provide that. And how do we use hope to manage the entire episode, including and really drive that plan of care?
Oh my gosh, Raianne, I love that, because you are so right. We're on the next generation of RN case managers. I mean, Valley's been in existence for over 40 years. So I've been in it 22, and I'm seeing them retire, and the new ones are coming on, and the census is growing. So having that basic, that fundamental, what does it mean to be an RN case manager? It's back to the basics, right? It is back to the basics. And when you teach that from that foundation, and, the assessment, and I would add to pull in that pharmacist. I was trained that every admission you went out, you gave this beautiful assessment to your PharmD. That's when the magic happened. They would come in and you'd work on the symptoms until you had a med for every symptom or non-pharmacologic intervention. And then the physician completed the trifecta. When you do that and you teach that, then you aggressively manage that symptom from a place of depth. And that just reminded me, double down on the basics, go back to the basics.
Absolutely. And I'm just going to say that when I'm sorry, Chris, that it's the Raianne and Andrea
This is
show.
good. This is what I knew was going to happen, just getting you two together.
No, listen, when you have standardized protocols for each symptoms that everybody follows the same way, everybody, in concert with your PharmD, everything I learned about hospice medication, I learned from my PBM. I learned from my pharmacist, everything. And so having standardized protocols for dyspnea, nausea, pain, neuropathic pain, all kinds of pain that everybody follows the same way is setting up the entire team as well as the patient and family for success.
And that's it. And that expertise. So Dr. Byock, how I love Dr. Byock and his 4 strategies, pathways forward. And that one that I think is first and foremost is defining our expertise and what that looks like and what it takes. And the certification for CHPN, we are focusing on that, and we are ensuring that everybody that's been here 2 years gets that certification. And when you do that and your nurses become more confident and competent, then when they're speaking to the physicians, they're speaking to families, it comes from a place of expertise, not a model of care that's 40 years old. This model of care has been, sharpened and perfected. And, it was started with cancer, and look what NPHI has even done with all the non-cancer diagnosis. Dr. Muir's work on, American Heart Association, Lung Association. Now we have drilled it down into those places where the studies show when you have hospice and some diagnosis, you live longer because of what we do, the symptom management, the quality of life. So then it's like putting that stake in the ground that it's not just by chance that happens. It's the expertise.
Well, let me ask this question. This is kind of a segue, but I think it's going to maybe have you answer what you just did, maybe a slightly different way. I do think a lot of people are treating hope as the next HIS. You've suggested it's much more than that. It's a broader chassis. So what fundamentally changes in how an organization operates if they take that perspective more seriously than, oh yeah, we've been there, we got the HIS t-shirt, this is just the next iteration of that?
Well, I'll start off by saying hope becomes the shared clinical language that drives real-time decisions.
What does that mean?
What that means is that we're all, instead of speaking a dialect, we're all speaking the same words. All words that we're speaking in regards to hope mean the same thing to all of the stakeholders. And, what I found, I was at, I think, about 15 state and national conferences last year speaking about hope. And I'm going to tell you the thing that startled me most, that everybody trained their team how to use the hope tool within the EMR, but no one shared how do we correctly answer them?
That's what. Yes.
Right?
Right. That's it.
You're speechless, but it's true.
But it's speechless,
true. I would ask them to raise their hand. Raise your hand if you taught your team how to accurately score the hope question. Not a hand in the room. 15 different conferences. Not a hand in the room went up. So we got to go there. Make sure that we're all the answers to the questions all mean the same thing to the people who are filling them in. Otherwise, you're going to get all kinds of confusing and contradictory answers.
Oh, you're giving me flashbacks. So in Oasis, what happened was, because we were the beta there, we understood the content and the context. So if your admission nurse did not answer the questions at the lowest level of the patient's care, so say they needed 2 assists, but that admission nurse said 1 assist, you weren't showing the progression of the outcome. So same thing with hope. If we don't understand then I'll answer it the same way, we're not going to show the outcomes consistently. And that's not going to be good for the organization or the industry. So totally agree.
Gosh, I love both of your answers, and I'm trained as an accountant, and we experience this on the accounting level. Like, let's say you call a category marketing, but if you don't put a definition of what you mean by that, you've got different invoices being coded to different things. And so this is the wisdom of a taxonomy. So Andrea, I know we always joke, like more than once you've showed me your hope manual that you have. Is the hope manual, like, how do they know that right taxonomy? There you go. If our viewers could see, Andrea just put up her manual. So how do they know the right taxonomy? Do they need to print the manual? And then is that what you were kind of teaching from Raianne, or what would you say?
I would say that you need to have a good educator, and you need to go section by section that for those areas that are going to impact each group. So, the administrative section is different than the clinical section that is different from, section Z. So, for those clinical questions, I would go one section at a time. I think it's a great IDG activity. You've got the team together. Today, we're going to go over, dyspnea. Today, we're going to go over the pain assessment, and just make sure that everybody knows that for a lot of the hope questions, you're checking all that apply. And if they don't know that you're checking all that apply, they're not going to do it. So in my mind, it's also engaging, find out who's doing it well, which clinicians are doing it well. And they're usually the informal leaders, and bring them in and, to lead the charge and to demonstrate where they're good.
I would agree with that. And I think those sections on the assessment of symptom management, what tripped us up a little bit was severe, moderate, and mild. And the WHO ladder teaches us that in pain, but what they're looking at is the impact. And that's where the subjectivity lies. The impact of if it's severe, moderate, and mild. And so spending time talking about that and looking at the intent and answering and giving scenarios. We had several training sessions that gave real patient case studies so that we're sitting in a group and go, okay, and just like Raianne says, what would you say this impact is? Severe, moderate, or this? What would you say? And then talking that through. So it gives them time to process all this, because that's the next step. And the more you talk it through and weed out all the subjectivity and come to an understanding, then when it's time, it's just a very natural thing of what we do. We're just saying it the same way now. But it does take a little bit of time, because when we did that, we found that there were 3 different opinions at the table, because that's not something we were taught. We weren't taught about the impact of a symptom and what means severe, moderate, and mild. So then let's look in the manual and let's see what they're talking about. And so that was one of the most helpful exercises we did with through Leading Age Ohio. They started that with us and they gave us the tools, and then we took it back and we talked it through. Yeah, that's very important.
This is so good. So I knew I'd learn a bunch just listening to both of you. But, one of the things that always strikes me, one of my nursing mentors when I grew up in hospice, which is over 30 years ago, would talk about how hospice was so much art. But every part of medicine, you have to have an art and a science. And the problem is when we treat it all art, right, there's so much kind of latitude for variance. And that's the problem today, is now we have so much variance throughout America. So when I'm listening to you, I could see where you can really get your, well, as Andrea's words earlier, just get your quality just really dialed in, very much more precise and not as much left to chance, where we just hire a lot of caring, compassionate people and they just do caring, compassionate stuff, just seeing where they bring more of the science into this.
Don't miss part 2 of this episode coming this Friday.